Umesh, we can start.
Can start, sir.
Okay, Lavanya, please go
Yeah.
ahead.
Good morning, sir. Good morning, Srinivas sir. Good morning, Ghanshyam sir. Thank you for giving me this topic. Myself, Dr. Lavanya, consultant in medical hospital. Today, our topic of discussion is two discrete topics: brain death declaration and end of life care principles. Uh, Brain death. In last be reversible loss of all respiratory and cardiac functions, which lead to putrefaction of the body. No longer functioning systems are there. But over years, from mainly 1960, when the advances of cardiopulmonary resuscitation and mechanical ventilation has come in, there is a zone where we can maintain the functions of heart and lung with the help of artificial supports. But the brainstem has irreversibly had a injury. So there is a now the terminology is brainstem death, which it is defined as irreversible loss of all functions of brain, including the brainstem. To say that one person is brain dead, it needs three essential findings: coma, absence of brainstem reflexes, and apnea. So when once the person is the patient is determined brain dead, that means patient is legally and clinically dead. So what is the Indian context? Who gives the rules for brainstem death declaration and the regulations for the same? Previously, in 1994, transplantation of human organs was passed in Indian Parliament. The next year, they have laid down the rules for the brain death certification procedure. Not all hospitals have organ transplantation. In that case, the hospitals can actually declare brain death, and they can be a potential organ donation area only for the retrieval of the organs, not for the transplantation, but they have to be registered with the prior for the same. They are called non-transplant organ retrieval centers. In 2014, whether you call it TOTA or TOA, Transplantation of Human Organs Act, there were amendments made in the same. And also, whoever is declaring the brain death, the team of doctors, have to get registered and approved with NOTO. That is National Organ Transplant Organization. So, what is the anatomical and physiological basis of brain death? Brainstem has a compact nuclei of 10 last 10 cranial nerves and ascending and descending tracts. Because it is a complex network, even the smallest injury, even very small lesions, can destroy the vital respiratory and cardiac centers, and then they can disconnect cortex, cerebral cortex, from the brainstem. And also, damaged reticular formation may lead to loss of cognition and persistent unconsciousness and coma. Reticular activating system is the responsible for the wakeful consciousness. When it is lost, the patient is completely unconscious and in coma. So this slide says about the region of brainstem. When the function is lost, what happens? The core of the brainstem, where reticular formation and reticular activating system are there, it is responsible for consciousness. When there is a lesion, there is coma. Same way, respiratory centers in pons and medulla, the respiratory drive is lost and loss of spontaneous breathing is there. Cardiac vasomotor centers are present in medulla, which maintain BP and heart rate. When the lesion is there, both are lost. All motor and sensory pathways are which mediate motor and sensory impulses, which leads to complete anesthesia and bilateral motor palsy. Cranial nerve nuclei lesion leads to bilateral reflexes. Cranial nerve reflexes are lost. So, what are the main causes? There may be a lot of causes, but the commonest causes of brainstem death is a traumatic, direct traumatic injury to the head, severe traumatic brain injury, subarachnoid hemorrhage, ischemic stroke, intracerebral hemorrhage, and hypoxic ischemic encephalopathy post cardiac arrest status. So what happens in brainstem death? There is a severe damage of neuronal tissue, which leads to cerebral edema, and there is increase in ICP. This increase in ICP further leads to decrease in cerebral perfusion. And this is a vicious cycle that keeps on occurring until no blood enters the cranial cavity. And there is a transtentorial herniation, which leads to coning. So there is a herniation that crushes brainstem also, and there is permanently dysfunctional brainstem. Also, in cases of hypoxic ischemic injury, there's another pathophysiological mechanism, that is late neuronal injury by reperfusion mechanism has been studied. So now brainstem death being why we are so much worried about this. In India, the awareness is still low. There is the as they're not they're very aware of the how to what rules are there for brainstem death, and also legal charges that are associated with, and there is a fear of diagnosing this one, and hence in India it is still the awareness is low. So who should diagnose? It is all rules are laid by THOA, that is Transplantation of Human Organs Act, and amendments were made in 2014. Initially, it was a medical administrator, and the four people, the team includes medical administrator in charge of the hospital, intensivist or anesthesiologist. This has been added in 2014 amendments, where anesthetist or intensivist in the non-availability of neurosurgeon or neurologist has been allowed to do the brainstem death declaration. The third one is neurologist, neurosurgeon, medical officer treating the patient, the primary physician. So all these, the team of doctors prior has to be registered with the NOTO for the purpose of testing and declaring brainstem death. If there once to proceed with the brainstem death certification or declaration, there are certain prerequisites which have to be evaluated. On clinical evaluation, this is to determine the cause of coma and irreversibility of the coma. If at all there is any in between any of these team members or the primary physician or any of the team members, if there is ambiguity, the benefit of doubt will be given to the patient. We will have to wait for the further testing. There should be the patient who is on CNS depressants and drugs like sedatives. If the patient's hepatic and renal functions are normal, at least 5 times of the drug's half-life it will take to completely eliminate the drug from the body. So we'll have to wait for that. And neuromuscular blocking agents, at least that is mentioned as at least 6 hours before the testing. And sodium level should be between 125 to 159 milliequivalents. The severe acidosis, alkalosis should not be there, and there should not be any thyroid or other endocrine dysfunction. And also, the patient should have a normal core temperature, at least more than 36 degrees. If at all any hypothermia is there, that should be corrected accordingly. And to have a normal systolic blood pressure, at least above the 100 millimeters of mercury. If at all it is below that, vasoactive agents can be added. Now, apart from the prerequisites, there are some confounding factors mentioned even in Jeevan Dan and also TOA. The confounding factors for the brainstem death declaration are shock or hypotension, hypothermia less than 32, drugs which can alter the neuromuscular function, and EEG testing also, like anesthetic agents, neuroparalytic agents, barbiturates, benzodiazepines, alcohol. All these have to be ruled out. Brainstem encephalitis and Guillain-Barré syndrome can be confounding to the brainstem death declaration. Encephalopathy, that is hepatic encephalopathy, uremic and hyperosmolar coma can confound the brainstem death. Even severe hypophosphatemia can be a confounding factor. So we have to eliminate or rule out all these confounding factors, then go ahead with the testing. So like I said, 3 main factors that should be there: coma, absence of brainstem reflexes, and apnea. The coma, that means patient is completely unresponsive. There is no eye opening or eye movement to noxious stimuli. And sometimes there is, we may get confused with the spinal reflex, that is triple flexion. This is a response to noxious stimuli. This can be present, and it is not a not considered as any reflex, brainstem reflex. So it should be differentiated from the cerebral activity. It is consistent, even if it is present, it is consistent with brainstem death. Absence of brainstem reflexes. The most important reflexes that are to be checked are pupillary reflex. It should be absent in both eyes, both to direct and consensual light. And the one, as we know, it is a normal thing to do, that is shining a bright light in pupils and observing no contraction should be seen. As it is told, pupils should be in dilated or semi-dilated position, but it can be of normal size. It is even mentioned. And it is not reliable in certain conditions like post-cataract surgery, trauma, high-dose dopamine and atropine, and patients on other drugs like monoamine oxidase inhibitors. It may give wrong result. So it is not reliable in those patients. Corneal reflex, the cornea is touched with a tissue paper or a cotton swab, and observe for any eyelid movement, it should not be seen. And pharyngeal, that means a gag reflex, and tracheal, that is a cough reflex, that is done by either oral suctioning, the gag reflex can be checked, and endotracheal suctioning, cough reflex can be checked, or even a direct pressure over the trachea and the neck, we can check the cough reflex. And absence of facial muscle movement to a noxious stimuli, that it's mentioned in the criteria, but not a very commonly done thing. Applying deep pressure on the condyles at TM joint and supraorbital ridge, no grimace should be seen. The most important reflex, another reflex is oculocephalic reflex, which is called doll's eye phenomenon. So for this, the prerequisite is there should be stability of cervical spine, and the head is briskly rotated horizontally and vertically. There should not be any movements relative to the head movement. So that is absent doll's eye, that is called. Head is in fold caloric test, even warm caloric test, both can be done. Here, head is elevated by sufficient head elevation should be done, and external artery canal is irrigated with the cold water. The temperature should be 30 degrees, and the volume is 20 to 50 ml of water. So, for 1 minute, we observe for any movement of the eyes. So, here this picture shows both the reflexes. If it is a cold water, in the normal brainstem, the eyes would move in the same direction as that of the cold water irrigation onto the same side. And in case of warm water, it will be onto the opposite side. And normally, the eyes, this is the oculocephalic reflex, where normally the eyes would move in the opposite direction. If you move to the right, then the eyes would move in the left direction. In brainstem death, there should be absent reflex. There should not be any eye movement. So this is the afferent and efferent cranial nerves which are responsible for the reflexes. Pupillary light reflex, cranial nerves 2 and 3, which is in the midbrain. And caloric test is cranial nerves of 3, 6, and 8 in the midbrain and pons. Oculocephalic reflex 3, 6, and 8, same things like a caloric test, midbrain and pons. Corneal reflex is 5 and 7. Gag reflex is 9 and 10. Cough reflex is 10. Vagus nerve function, again, this was mentioned that atropine challenge you have to give and see for the heart rate increase. That is cranial nerve 10. And response to painful stimulation in trigeminal nerve distribution, cranial nerves of 5 and 7. Apnea test is for the respiratory centers present in the pons and medulla. So how to conduct apnea test? This is the core test of the brainstem death testing. It is defined as the absence of respiratory drive in presence of CO2 challenge. As it is very risky, you have to, due care has to be taken to ensure safety of the patient. When we cannot do apnea test at all, when there is when there is hypotension, systolic blood pressure of less than 90, despite vasopressors if it is not maintained, hypoxemia, PO2 of less than 90, sorry, severe acidosis, pH of less than 7.2. So, the prerequisites for apnea test almost similar, which are normal stable BP, systolic blood pressure of more than 100, normothermia, euvolemia, eucapnia, absence of hypoxia, no evidence of prior CO2 retention is there. So, how to prepare the patient? Initially, try to achieve eucapnia by ventilator rate and tidal volume, check a baseline ABG. After that, pre-oxygenate the patient with 100% FiO2 at least for 10 minutes to maintain PaO2 of more than 200, which is ideal thing to do. And whenever we are doing this test, it is better to have arterial line in place to have the repeated ABG sampling and also continuous BP monitoring. And how to do it? Once they expose the chest of the patient and abdomen of the patient to see any spontaneous respiration is occurring. And ET tube is disconnected from the ventilator, and there is a nasal cannula tubing that has to be kept in the insertion into the ETD tube towards the tip of the carotid. At the level of the carotid should be kept, and with the insufflation of 6 liters of oxygen. And monitor oxygen saturation and monitor BP. If at all pressure is falling, support with the vasopressors and draw ABG after 10 minutes. So, how to interpret this ABG or apnea test? If the PaCO2 raises at least 20 millimeters of mercury above the baseline or more than 60 or equal to more than or equal to 60, PaCO2 is a positive test. If PaCO2 has not reached the threshold, we can continue apnea test as mentioned in the guidelines. And you can assess further ABGs until threshold is reached if the patient is tolerating. If patient's oxygen saturation is less than 85 for more than 30 seconds, or if SBP is less than 90, we have to abort the apnea testing. And usually the brainstem death declaration is based on clinical examination, and 2 times the clinical examination and apnea test performed twice. It is sufficient for the brain death declaration. It is sufficient. No additional testing is required usually. But when it is not feasible or it could not be completed because of the low BP or low saturations, it could not be finished, or it is equivocal, the doubtful test results are there. And this is and when patient has color cervical injury or cardiovascular instability is too severe, when we could not perform apnea test, these are the only indications for ancillary tests, but otherwise usually declaration is clinical. The ancillary tests that have been used or most important ones are electroencephalography, the absence of electrical activity during at least 30 minutes of recording, and because of multiple background noise, and there can be multiple artifacts in the EEG. And the other one that we commonly do is CT angiography or conventional angiography can be done, and any other kind of angiography, magnetic resonance or radionuclide. All these angiography, there should be absence of intracerebral filling at the level of bifurcation or circulophilis. And so other ancillary tests, radionuclide angiography, MRI angiography, but it will be very challenging with all the tubings and hypotension, hemodynamic instability to carry the imaging. Cerebral arteriography, nuclear brain scanning, where there is absence of uptake of isotope in brain parenchyma. And somatosensory evoked potentials can be done. And transcranial Doppler ultrasonography can be looked at because it is done bedside, no need to shift the patient. The finding will be small systolic peaks in early systolic without diastolic flow or reverberating flow. This indicates very high vascular resistance, which is associated with high ICP. And so after doing all these tests, this whole procedure, the clinical examination of checking the coma, the absence of brainstem reflexes, and the apnea test has to be repeated a second time after a gap of 6 hours. As I've already mentioned, a set of 4 doctors performs the first and second apnea test. And in this team of doctors, the persons who are involved, the doctors who are involved in harvesting and transplantation cannot be a part of this team. By this time, a transplant, at least by a first apnea test, a transplant coordinator would have been involved by now. So in the second test also, all of these reflexes and this has to be repeated, and apnea test has to be repeated. When I've gone through some of the lectures and also some articles have mentioned one apnea test is sufficient, but having gone through multiple articles and TOA Act, it says that two apnea tests have to be conducted. So the time of declaring a patient dead after the second test is the time of completion of the second test. So having done all this, it has to be thoroughly documented, which is the most important thing because legally it can be used. In the medical record has to comprise of etiology and irreversibility of coma, absence of motor response to pain, and absence of brainstem reflexes, which are tested 6 hours apart. Absence of respiration, that is apnea test, PaCO2 with more than or equal to 60, or apnea test positive. So, and for justification for all these confirmatory tests. The next step is the intensivist has to take the responsibility of both brainstem declaration and to notify next of kin, the next step being that. The facility should have good efforts to notify that person closest to the patient. The next of kin has been clearly defined in TOA Act, where it said the spouse is the first one, the next of kin is spouse, or the next the hierarchy has been defined as the parents, the son, daughter, parents, and then any other close friend or who has brought the patient or who has been closely associated and has been coming to hospital regularly and who knows the patient's condition. Maybe even the other one more conflict, the doubt has been whether to take the consent for apnea test. So it was mentioned in some of the articles again that consent has to be taken prior apnea testing. But the consent overall, it says that consent need not be obtained, but request for the consent is not required for the apnea test, but can be notified to the patient. That has to be decided. So the religious beliefs of the patient's family and these has to be respected, and the same thing has to be told to the hospital staff, caregivers who are taking care of the patient. So that is about the brainstem death declaration, which follow after that the involvement of, if at all, there is a plan of the organ donation and transplant coordinator will be involved, and further steps will be taken care of. And the brainstem, the maintenance of brainstem donor is beyond the scope, so I did not keep it. The next topic is end of life care principles. It is the joint mission of intensive and palliative care. So the explosion of technological advances in medicine must be balanced with the culture of holistic care. So the human-centeredness in the same both palliative care and intensive care has to be, it is involved in the end of life care principles. So why in India, even till now, India ranks low in cases of these end of life care guidelines, and to have a successful end of life care documentation and the proceedings. So what are the barriers that are there? There is a lack of attention to the needs of dying. There is a reluctance to discuss anticipated death or make ethically challenging decisions. There is a fear of legality behind it, behind that is involved in the end of life care. Physician and organizational concerns over the legality of foregoing of life-sustaining treatments. Families' inability to pay, financial concerns are always there. Lack of integration of palliative care in ICUs. So this is published, the consensus position statements were published in February 2024 by Indian Society of Critical Care Medicine, along with that palliative care medicine, Indian Association of Palliative Care Medicine. Both have published a consensus and position statements. So I've kept some of the position statements to be remembered. So quality of dying is as important as any other quality of ICU care. Quality of life and quality of dying are equally important. So while transitioning to palliative care, it should be the emphasis is mainly on the patient suffering than a legality of treatment limitation. We have to take that step for the patient suffering. And to keep in the mind that severe irreversible disability, which may be burdensome to the patient, should be included as the main reason in a treatment limitation decision. And ICU admission criteria wise, it should exclude patients where the ICU care is of little benefit or the trial of ICU care is excluded. So we need to choose based on that criteria. And when EOLC, the end of life care plan, has been made for the patient, only in certain circumstances, ICU admission can be continued. Where the symptom control is not possible in the ward side, it has to be done on in the ICU only. And the goals of, in that case, the goals of care have to be communicated with the family and caregivers. And also, when there is a organ donation can be done for the particular patient, can be kept in ICU for some time. And in all these end of life care decisions, a leadership role has to be taken by the intensivist in having the multidisciplinary team meetings and family meetings. So, while we are discussing with the patient family the treatment options, it should be mentioned as a potentially in a you while you also convey that there are potentially inappropriate treatments going life sustaining treatments, and there is an option called palliative care that also should be mentioned as a standard of care. So the medical team, how to initiate, how to start a EOLC. It should initiate serious illness conversations guided by a checklist has to be always there, and a policy has always should always be there for EOLC in any hospital. They should not take unilateral decisions, and they should provide only the recommendations, not merely a menu of options. So if you keep on telling about the options that are possible, you do whatever you want, they might get confused and they might be very emotional. So we have to act with empathy. So it should not burden giving a lot of information and telling the patient, they should not, patient's family should not burden them with the onus of taking treatment limiting decision on their own. It should be a shared decision making always. And just because we are not able to handle this patient, there's nothing to be done for this patient, we cannot suggest a LAMA process. And when there are ethical and financial dilemmas. So our own views are not important. We have to put everything in front of them and tell the facts always. And for our convenience, we are using a term futility, but it should not be. It sounds like it is undervaluing the worth of the patient's life. So better to avoid, at least for the sake of counseling and talking to the family. There are two important things, that is withdrawal and withholding of the treatment, that life sustained treatments that are going on. That I'll be talking in subsequent slides. There should be professional training for end of life care, which explain competencies in EOL communication, general palliative care, knowledge of biomedical ethics in decision making, and application of various modalities of treatment limitation like withholding and withdrawal of the supports. And all hospitals should have EOLC policy and standard operating procedure for treatment limiting decision taking, so that nowhere it will be difficult to take the steps. And so how a patient wants to, how any person wants to die. The constituents of good death are effective communication and relationship with healthcare providers, performance of cultural, religious, or other spiritual rituals, and there should not be any emotional distress or psychological stress, autonomy, the ability to take decision by themselves, with regards to treatment related decision making, dying at about the place, at the preferred place, not prolonging life unnecessarily, awareness of the deep significance of what is happening. Otherwise, they will go into a depression while knowing that there is a death is inevitable. Emotional support from family and friends, not so which of the family or which friend has to stay with them, that should be able they should be able to decide. Not being a burden on anyone, relief from physical pain and other physical symptoms, and the right to terminate one's life. So, what are the ethical and moral dilemmas in end of life care? Ethics, what is ethics? It is a sense of moral right and wrong, what one ought to do and what one should desist from doing. What are the usual ethical principles in medicine are applied to the end of life care also. Autonomy means right to self-discrimination, that is, right to exercise one's choice. But when they are not able to do so, there are other methods called advanced medical directive, which has been in place, and also the surrogate that can take who can take decisions for the patient. Beneficence, so acting in a manner that would promote the patient's well-being. Whatever treatment directives are there, they should always be in the direction of patient's well-being. Non-maleficence is doing no harm. For example, in cases of palliative care, if we give some pain medications, that may cause unexpected side effects, which are okay with respect to real legality of that. Distributive justice, sorry. So, with respect to the all patients should be treated same, irrespective of the age, gender, religion, race, and ethnicity. So, all these principles have to be followed in end of life care uh, treatment, end of life care guidelines. How to resolve ethical dilemmas that occur during the EOLC. So define the problem. When, for example, if the patient requires a ventilator support or a tracheostomy or any other life-sustaining treatments. So what are the benefits or harms by doing? Whether any benefit occurs to the patient or the patient has a suffering from it, or the is it harmful? The doing that treatment is harmful. So elicit patient's preferences and discuss quality of life with and without interventions in addition to longevity also. So it's not only about the longevity, it is about quality of life till the patient lives. So in put it to the in context of family and socio-economic circumstances. So when there are the questions related to novel technologies, like for example, patient is on ECMO, patient is on circulatory support, but overall it is futile to continue. And is it like every day we should ask whether is it a bridge to our recovery, or it is like we are simply prolonging the life, we're simply prolonging the suffering also. And in that case, maybe we need to take a decision whether to withdraw that ECMO. And ICDs, implantable cardioverter defibrillators, when the patient is on that. And at the end phases, last phases of life, if that is there and giving distressing shocks, then we have to decide whether that should be removed or switched off. So, when how do we know whether this patient is for end of life care or no? Whether how to identify these patients potentially. So, some of the examples that are given for identifying the inappropriateness or for continuing the treatment. So, for example, in catastrophic brain injuries like traumatic brain injury, ischemic stroke, hemorrhage, brain infections, or septic encephalopathy with coma, and there is unlikely that there is a meaningful neurological recovery in future. And in the critical illness, in the background of irreversible severe neurological disability, like patient who has already have muscular dystrophies or quadriplegia in the background, and then now come with the critical illness. And also who have critical illness with the background of advanced dementia and permanent vegetative state due to any other reason like stroke. Um, Post cardiac arrest anoxic ischemic injury. If the patient has a motor score of less than or equal to 2, and neurophysiological markers, poor prognosis markers are there more than 72 hours after ROS. Sorry. Advanced or metastatic malignancy is there with a short median survival rates. And advanced age with multiple comorbidities and low probability of success, and or not, and patient has declined the same. And there is acute decompensation of chronic end-stage organ failure, like any of the organs, and no option of organ transplantation. And multiple hospitalizations are going on happening. And worsening of multi-organ failure, you can use scores like SOFA also for identifying these patients. SOFA more than 15, and multi-organ failure is worsening despite a reasonable trial of organ support. And if there is a valid advanced medical directive, which I'll discuss in subsequent slides. And for ask the question, would you be surprised if the patient is alive at the end of 6 months to 1 year? Unlikely. If the answer is yes for this question, then we should proceed for the EOLC. These are the most potential patients, or how to identify a EOLC patient. And some of the definitions and how to, foregoing life support decisions, whether to stop, to continue, to withdraw. So some of the definitions have been given. Terminal illness is defined as an irreversible advanced disease condition where death is expected in less than 12 months. Withholding the treatment means not initiating or escalating a life-sustaining treatment. After the either in response to an informed refusal by the patient, or as per AMD, or as per the family. If withdrawal, that is stopping or interrupting a life-sustaining treatment, is done, it is called withdrawal of life-sustaining treatment. Again, in court of law, it has been said that both are the same. That I'll discuss later. Best interest means a principle that behooves physicians to ensure that potential benefits of the treatments outweigh the harms. So always it should be, if there is no therapeutic purpose for the particular treatments, it is better to be avoided. So that is best interest of the patient. Shared decision making, again, either with the patient, if patient is not able to take the decision, along with the family or appointed proxy as per AMD. There should be a dynamic exercise, there should be multiple meetings, and shared decision making has to be undertaken. Advanced medical directive, it is a written declaration. Any person who is above 18 years, they can write a written declaration where there is when there is a decision making capacity, and in future, if there is a time where they cannot take the decision for their treatment, it is written in the document how they would like to be medically treated if that scenario occurs, and or treated if they lose capacity at that time. So how they will be treated, should be medically treated, is already written in prior, so that it is clear for the even the surrogate of that for that patient is also mentioned in the advanced medical directive, so that they can also take decisions for the patient at that time when the patient cannot take decisions for himself. Because most of the patient come in this very critically ill kind of situation, so they cannot decide for themselves. That's when this comes into picture. But a valid advanced medical directive is very important to check the document thoroughly and has to see the validity of that. So there are two terms: do not attempt resuscitation, where when there is again considered decision is taken to not perform CPR. So that is called do not attempt resuscitation, or do not attempt intubation. Do not intubate is where to not intubate the patient in the event of any other the severity based on the severity of the condition. So let us go through one or two case scenarios where end of life care has to be considered. 80-year-old female who is a hypertensive diabetic, known case of dementia since 10 years, progressively worsening over last 2 years, which she required multiple hospitalization for the same, and she's been bedridden since 1 year. Now she has presented a fever, cough, shortness of breath, decreased urine outputs. With initial evaluation, provisional diagnosis of hospital-acquired pneumonia with acute kidney injury was made. Despite the routine supportive management and oxygen supplementation, she was rapidly worsening and she may need mechanical ventilation and renal replacement therapy. How do we manage this case? Another case scenario, a 70-year-old male who is a hypertensive diabetic ex-smoker, known COPD, known coronary artery disease, post-PTCA with a severe LV dysfunction, known malignancy of lung, underwent chemo and radiotherapy 8 months back and stopped it later. And now presented with grade 4 SOB and admitted to ICU with a supportive management like O2 and NIV support. Patient did not get better. Also, imaging showed multiple skeletal mets and liver mets, being a poor advanced carcinoma. On day 2 of admission, patient has further worsened and desaturating even on NIV support. What will be our next step in the management? So there is, in all hospital, there should be a clinical pathway for end of life care approach. So at all steps of end of life care, there should be accurate documentation has to happen at every step. So initial step is to looking at these cases. If the physician, either primary physician or intensivist or any other doctor involved, if the after objective and subjective assessment of the patient, if the doctor thinks that there is inappropriateness of the life sustaining treatments, then the first, that is the first step of end of life care. Then he has to this consensus of assessment has to be by the primary medical board, which the primary medical board contains a primary physician and two other experts in the same field for more than 5 years of experience with that forms the primary medical board. And once there is a consensus among these doctors, then initial conduction of the multidisciplinary patient or family meeting has to be done, and the family has to be updated regarding the clinical status, what is the prognosis, what are the ongoing treatments, and what are the therapeutic options. So this is to gain the trust from the family, the relationship with the family and the trust from the family. And this initial meeting is not for start telling them this is the option, palliative care is the only option, but giving disclosure of all patients' condition and the prognosis very clearly in their own understand language. So after this, in subsequent meetings, there should be a shared decision making for treatment limitation. So again, here, if there is with the family, we can confirm, and also we can check the validity of advanced medical directives, if any is available, and any surrogate is available if AMD is not available. Then if nothing is there, then we have to work with the family. If there is no consensus at this point, if the decision making of going for an end of life care, any of that withdrawing or withholding, then we have to continue full support till the conflict resolution happens. For the conflict resolution, you can take an expert opinion or ethics committee opinion can be taken, and also family physician can be involved here, and also non-medical decision support can be taken. So once the consensus is there, there is a shared decision making among the family and the medical board. This plan has to be conveyed to the all healthcare providers. There should be consistency in the care plan. It should not be like the doctors know and the caregivers don't know. There should be a consistency in the care plan. And further, foregoing life-sustaining treatment, the primary medical board, whatever they propose, that whether to withhold or withdraw the support, that should be submitted to the secondary medical board. And it's only that it's not approval, but hospital informs the district jurisdictional magistrate of the first class. And then the implementation of the withdrawal or withholding decisions and ensure effective palliative care. After this, we need to address the physical and emotional, spiritual needs of the patients and family, be very empathetic, and take care of them through the grief and bereavement support to be given to the family because they are losing their closed ones. And after all this, there is a quality control of the care process. So every hospital should have a clinical pathway for the EOLC. The most important thing at every point is to have accurate documentation of the each step. And why there is a communication intervention in EOLC? Why is it it gets so difficult sometimes to talk to the family and communicate with the family? To elicit complete information from the family or surrogates, that is history of the illness, since patients are often too ill to be able to speak for themselves. And it is difficult to build trust and confidence with patients and families, essential to providing emotional support. For conveying prognostic information, ensuring families' comprehension and goal concordant care. To break bad news tactfully, and to elicit patients' values and wishes from family or surrogates to initiate conversations around goals of care in patients facing terminal illness. To accomplish shared decision making for life sustaining treatment decisions, the foregoing life sustaining treatment. So far, it is possible to prevent or resolve conflicts with the families, to resolve conflicts within the treating team. So, to provide colleagues a supportive climate to foster professional integrity and satisfaction, preventing burnout. So, basically, all these are, say, all points for communication interventions. What are the issues that we may face at every step? So in the communication, there are just some of the in consensus statement. It has been mentioned some of these word or phrase choices which may help us in certain situations. For example, warning shot, ask permission to proceed. To ask that, do not say I'm going to be frank. You must be strong and face it. That appears a little difficult to process. So hence say that I wish I had more positive updates for you. Are you okay with me going ahead and sharing some vital information with you? Likewise, some of these word phrase choices have been told to help us uh, tide through the situation. When faced with big emotions like breaking a bad news, so instead of saying calm down, please relax, control your emotions, please be strong. So we can say something like, I can understand this is a distressing time. It is okay to take a pause for few moments. Is it okay for me to proceed with the update? So every now and then we can ask them whether they are understanding, and then whether is it okay to proceed with the update. So likewise, some of the word phrases have been given. And also the active listening technique, solar approach, where you face make a squarely face. That is, the whole of your face is seen. And they are able to listen to you, and you are sound should be sounding like you are actively listening. And open postures, open arms, and always lean in between the discussion, lean towards the speaker, and eye contact has to be made always, and have a relaxed position. This is a solar technique for a active listening method. And multidisciplinary family meeting, how to conduct this one. At the first meeting, have a suitable meeting places. All relevant people should be attending the meeting, and have enough time with minimal interruptions. Whenever, if possible, whenever necessary, use a local language that they can understand better. Even cannot use medical words where they'll go into a confusion state. Build a relationship and value, respect the family, and take care of nonverbal communication, gather information, connect to the story, hear them out a lot, talk less, allow expression of concern, identify and support emotion. Freely, talking freely helps families. Some use Most important thing is use non-technical language and be empathetic always. Convey and discuss uncertainties. Avoid focusing on numbers and statistics. So outline a plan, making sure it is understood. This is the first meeting, and the subsequent meeting also. Ask at the beginning. So ask what they know till now. How far have you understood the condition? And then clarify, and then again ensure they have understood. So ask approach. Update the status more frequently if things are not going well. Allow expression of concern. Identify and support emotions. Summarize and way forward. And like if you have to breaking bad news, you use the spikes protocol that we are all aware of. EOL discussions and decision making should be taken. Uh, Once the decision of foregoing life-sustaining treatments, whether withdrawal or withholding, has been taken, palliative care has to be continued, and the symptom management is very important. This is to even keep the patient. Comfort care has to continue, and also tell the family and to be satisfactory that patient is not in any pain is utmost importance in end of life care. So some of the symptoms and the treatment has been mentioned. So just prior to withdrawing during weaning to control visible distress, we can give midazolam morphine. Thirst or dry mouth can be like give some ice cubes to suck on sips of water. Artificial saliva can be given. For pain, have to manage with non-opioid analgesics, ketamine, and other drugs. Nausea with antiemetic drugs. Dyspnea, try to avoid fluid overload. Oxygen if tolerated, and NIV only if it mitigates distress. And also treat the pain also. That will lead to decreasing dyspnea. Delirium can be treated with haloperidol clonidine. Other symptoms like anxiety, constipation, fear and loneliness, and uncertainty, lack of sleep, lack of movement, discomfort have to be appropriately managed. Apart from this, spiritual support in end of life care is very important. If at all patient in the patient's family has a particular request that for the religious beliefs and any rituals have to be performed, it has to be allowed. When it is non-intrusive religious rituals or practices like any pujas have to be done, we should allow them. And also always hearing out empathetically without imposing one's beliefs. And if they want any particular area or quiet room for families for prayer and meditation, we should be able to provide them. So, what is the legal position of end of life care in India? So, an adult patient capable of making healthcare decisions may refuse life support even if it results in death. Life-sustaining treatment may be withheld or withdrawn under certain conditions from persons who no longer retain decision-making capacity. Advanced medical directive that meet specified requirements are legally valid documents. Active euthanasia is not lawful. So passive euthanasia is allowed. I will discuss the cases in subsequent slides. And the provision of pain relief measures that may incidentally shorten the life are lawful and do not constitute active euthanasia. And there is no specific legislation to provide the the guidelines on Eolc in India. The series of judgments that are given by Supreme Court, the principles have been laid down, the law related principles. So in India, the two main cases that have happened, first case is Aruna Shanbag. She was a nurse at a Mumbai hospital. She was in persistent vegetative state for about 40 or around 40 years. The caregivers have kept a petition saying, please to allow the euthanasia or mercy killing. The petition was rejected actually, but there was a breakthrough because the court said that passive euthanasia is allowed. That is, life-sustaining treatment could be withheld or withdrawn from persons without decision-making capacity, and when that is carried out in a good faith. So, the judgment also did not say that there is any difference between withholding and withdrawing. So there is it laid down a procedure also. After that, there's a Common Cause versus Union of India, where NGOs have for terminally ill patients, for the sake of terminally ill patients, they have kept a case against Union of India, where all these for withdrawal and withholding the the treatment, life-sustaining treatments. The specific procedure has been laid down, and in this case, where advanced medical redirective has been recognized legally, the fundamental right to autonomy, dignity, and privacy. Sorry. So this has been told after this case. So always shared decision making is very important. And when we are discussing, like I already told in brainstem death, the declaration is to be next to do next of kin. Usually their spouse and friend of long-standing friend who are staying with the patient, or sons, daughters, parents, siblings in that hierarchical order. So always documentation is very important. In the documentation should include time and date of meetings, persons involved in the discussion, medical details leading to the decision, including prognosis, statement of the patient's wishes and who reported valid advanced medical redirectives, options discussed, the agreed goals of care, treatments to be withheld, withdrawn, treatments to continue, signatures of the family member or legal proxy and the medical team. So it is very important to have a documentation, the form, the Eolc form, which mentions all these important components in the form. The part A should contain ratification of inappropriateness or futility of care, primary physician and primary hospital medical board. So why the futility of why inappropriateness is there? All the medical, the comorbidities, the current patient's condition has to be written in detail. Part B should contain discussion with the patient or the family or legal proxy, who is the main person that their details have to be mentioned. And also then inappropriateness or futility by secondary medical board has to be mentioned in the part C. And the final recommendations, which should include all life-sustaining treatments or things like feeding, sedation, NIV support, CPR, intubation, dialysis, all these treatments, whether patient family is which of these they want and which they do not want should be explained clearly, and yes or no has to be clearly written. And then the further the same thing, care plan for transition has to be made, and all the signatures with the primary physician and the it is mentioned here, it is mentioned as primary medical board and secondary medical board. So primary physician and the intensivist and other treatment of the other physicians involved in the treatment have to be clearly mentioned with the name and the signature and the date also. So this is the most important thing in Eolc. Thank you all. Thank you, sir.
Thank you, Lavanya. Srinivas, you're there?
Yeah, sure.
Thank you, Lavanya. I think you have taken through the two very important aspects of intensive care in great detail. I think there is common fear among all of us, when it comes to either palliative care or taking decisions about end of life care, or sometimes even certifying patients with brain death, because uh, we have centers where probably these things are well documented or well protocolized. But at the same time, there are a lot of peripheral centers where there's always this fear about what to do, how to proceed, how will the family react, and many times I think there's also lack of support from your fellow colleagues. We come across certain situations where our own colleagues tell ki, let us not get into this. We don't know what the family reacts. So these things often create doubts, or often create situations where we are not comfortable in going ahead with these practices. But I think it is time that everybody is aware of how to proceed with the end of life care, or certifying a brain death. I think the key aspect would be from my side, one, the importance of communication, uh, which is very, very important. And in the initial stages, we should give enough time for the family to speak, let them speak. Right? Many a time we are in a hurry to push forth our thoughts and our decisions, but we should hear them out patiently. Sometimes the concerns, the issues raised may not be very important, but nevertheless, it's always very, very important that you give them time, let them speak, and then have clarity about whether the care is going to be futile or not. Have a team discussion, and never, there should not be changing decisions. Like one day you're talking about end of life care, the other day you're talking about, you know, somebody within the team says, okay, let us try this. Those kind of doubts or those kind of changing instances should not be there. Whatever decisions you have a clarity about the thought about what has to be done, and then communicate the same to the family. It should not be that the team is confused and the family is confused, and never ever force your decision. Right? The family does not agree, respect their wishes and continue. Do not force. You as a team, you may feel that okay, the care may be futile, but do not force it. Give them time to come to terms with, and if they're not agreeing, I don't think we should pull off. Those are a couple of things that I thought we should kind of say. What's your thoughts?
Yeah, Shyam, I think you have summed it up. But what I would like to say is end of life issue, withdrawal of support, allowing natural death. These are all they look similar, but you can have an end of life discussion without withdrawal of life support. That means not to initiate something that is very aggressive for the patient. That is the point we need to understand. Two states have already officialized this process of end of life initiation, Odisha and Karnataka. I think it's a matter of time before other states also join. The ISCCM has actually has released a guideline which the Ministry of Health and Family Welfare has circulated to to all the ministries. It is yet to reach the judiciary, but it will probably another year or so. It will be applicable all over the country. When it comes to understanding the principle of end of life issue, it is just not one team which needs to be in sync. Certain specialities are more involved in such situations, especially surgical oncology, medical oncology, neurosurgery, for example. These are all specialities which are more medical neurology, for example. These specialities see such situations more often than other specialties, and everyone should understand that there is a finite limit to life of a patient, and the priority of any professional who is providing care to a patient who is dependent on life supports is to provide a dignified death. So, are we able to do it? Is the question we need to ask, and that should be your first step in identifying whether we are going to broach the point of end of death discussion. But most importantly, whatever it has, we talk about documentation is the most important aspect. That is where we run into trouble with our worries and our concerns, and some of our problems also come from our failure to document. And another confusion which we should avoid is end of life discussion versus brain death certificate. These are two different entities. One is a totally different algorithm. It is a different purpose, whereas end of life discussion is a total. If we can do that, I think we would have achieved a lot. In fact, in Criticare 2025, there is a 1 hour panel discussion with a lawyer, with a social worker, with a nurse manager, an intensivist, and a palliative care specialist on what are the obstacles to the implementation of end of life issues in India. Please do register for the conference. I think it will be a good learning experience for all of us. So, Shyam, that's all I have to say.
Thank you, Srinivas. Thank you, Lavanya.
Thank you, sir.
So, we have a discussion on EOL, how to implement it even during the Higgs 10 in June. So, those of you who are interested may please register for the Higgs as well. So, thank you for any queries, comments, or questions which you may have on the topic today. Please post them on the group from where you got this link from, and we will answer them at the earliest possible opportunity. Do register for Higgs 10. And we'll see you again next week with another session on the Higgs Learning platform. Thank you and have a good day. Bye-bye.
Thank you.
Please meeting.